Welcome to Public Health and Epidemiology. In this microlearning session, we will unpack how populations stay healthy, how diseases spread, and how evidence guides action. The simple illustration sets the tone: clear tools, practical steps, and real-world impact. By the end, you will recognize key concepts, metrics, study designs, prevention levels, surveillance systems, and the future directions shaping the field. Here is our roadmap. We begin with core concepts, then learn the main ways we measure disease. Next, we compare prevention levels and look at how surveillance systems keep watch. We also walk through common study designs before finishing with future directions. Keep these sections in mind as signposts. They will help connect ideas as we move from foundation to application. This section sets the foundation. Core concepts explain what public health aims to do and how epidemiology supports it. Think of it as the operating system behind every program we run in health. As you listen, focus on scale, prevention, and equity, because those themes will return again and again in later examples and case studies. Public health is about protecting and improving the health of entire populations, not just treating individuals. It spans prevention, health promotion, policy, and emergency preparedness, creating conditions for people to thrive. The goals you see converge on three outcomes: prevent outbreaks, enable healthy lifestyles, and ensure fair access to care. Together, these aims reduce inequities and raise the overall health of communities. Epidemiology studies the patterns and causes of health events in defined populations. By spotting who, where, and when, it helps explain why. Its role is practical: identify risk factors, monitor trends, test whether interventions work, and guide policies that protect communities. Keep this dual identity in mind. Epidemiology is both a detective searching for clues and a navigator steering public health action. With the basics in place, we can measure disease. This section introduces the core metrics that turn scattered cases into understandable patterns. As you hear each term, think about the questions it answers for decision makers: how many people are affected, how fast problems are growing, and how severe the outcomes are across a population. The panels highlight four essentials. Incidence tracks new cases over time to show risk and the speed of spread. Prevalence captures all existing cases at a moment, revealing the current burden. Mortality rates quantify deaths, helping prioritize resources. Case fatality shows how deadly a diagnosed disease is. Used together, these measures turn surveillance data into timely insights for planning, evaluation, and communication. DALYs, or disability-adjusted life years, combine years lost to early death with years lived in poor health. This single measure reveals the full burden a condition places on a population. Policymakers use DALYs to compare diseases, focus investments where they save the most healthy life, and track whether interventions are truly improving both longevity and quality of life. Now that we can measure problems, we need designs to study causes and solutions. This section introduces the main epidemiologic study approaches. Picture the divider illustration as a lab bench on which we arrange different tools. Each design answers specific questions, with trade-offs in cost, speed, and strength of inference. Observational studies watch what already happens. Cross-sectional snapshots estimate prevalence and explore associations at one point in time. Cohort studies follow people forward to measure incidence and link exposures to outcomes. Case control studies work backward from disease to compare past exposures efficiently, especially for rare conditions. Together, these approaches generate hypotheses and quantify risks that later trials can test. Experimental trials deliberately assign interventions to test cause and effect. Randomized controlled trials minimize bias by allocating participants by chance, creating comparable groups. When well conducted, RCTs provide the strongest evidence on whether drugs, vaccines, or behavior programs truly work. Their results shape clinical guidelines and public health policy, while also revealing potential harms and the contexts where benefits are greatest. Evidence matters most when it prevents illness. In this section, we organize prevention into primary, secondary, and tertiary levels. Think of them as before, during, and after disease onset. Building strategies across all three creates a safety net that reduces incidence, detects problems early, and limits long-term impact. Primary prevention stops disease before it begins. Vaccination, health education, safer environments, and supportive policies reduce exposure to risks and promote healthy choices. Because it targets whole populations, its impact and cost-effectiveness are high. When primary prevention is strong, we see fewer new cases, better behaviors, and healthier communities without needing downstream treatment. Secondary prevention finds disease early through screening and timely care, limiting progression and complications. Tertiary prevention focuses on rehabilitation and long-term management to reduce disability and improve quality of life. Integrating these strategies ensures continuous support for chronic conditions, aligning services so people move smoothly from detection to treatment to sustained recovery. To act fast, we must see problems in real time. This section looks at surveillance systems, the eyes and ears of public health. Picture the divider graphic as a network dashboard, collecting signals from clinics, labs, and communities to trigger rapid responses when unusual patterns emerge. Public health surveillance systematically collects, analyzes, and interprets data to detect outbreaks and guide action. The two frames emphasize both function and indicators. Reports of notifiable diseases, syndromic signals, and electronic health records feed dashboards that support timely decisions. By linking data to clear thresholds and alert protocols, surveillance turns information into response. Diseases ignore borders, so surveillance must be global. Networks such as international flu and foodborne systems share data across countries, speeding the detection of new pathogens and resistance trends. Their value lies in coordination and collaboration, ensuring information, expertise, and resources move quickly to where they are needed for control and prevention. Finally, we look ahead. Future directions blend digital innovation with climate and equity perspectives. Consider this as a preview of how tools and priorities are evolving so that public health can anticipate threats, involve communities, and protect the most vulnerable in a rapidly changing world. Digital epidemiology uses mobile apps, wearables, and social media analytics to capture high-resolution, real-time data on behaviors and environments. These streams can flag outbreaks earlier and target interventions with precision. Yet they raise challenges around privacy, equity, and data quality. The opportunity is to harness speed and scale while building trust, transparency, and rigorous validation. Climate change reshapes vectors, food systems, and migration, amplifying infectious and chronic risks. Persistent health inequities mean the same threats hit some communities harder. The path forward integrates climate resilience, digital tools, and equity-centered policies, pairing epidemiologic evidence with community action. This holistic approach strengthens preparedness and ensures benefits are shared fairly. Thanks for joining this microlearning on public health and epidemiology. You now have a toolkit of concepts, metrics, study designs, prevention strategies, and surveillance insights, plus a glimpse of what is coming next. Keep exploring, share what you learned, and apply these ideas to protect health in your community.